I'm glad to be here today with you all. And I have the pleasure of introducing Dr. Brian Andonian. He is an expert in many things related to lifestyle medicine and rheumatic disease, skeletal health, metabolic health, muscle health. So we're really excited to have him talk to us today. And his specific topic for us is immunologic wellness, how exercise and lifestyle impact immune competence in rheumatic disease. Brian, all yours.
Well, thank you, Kelly. Appreciate you having me. I was telling the group earlier that I took some time off clinic this morning. It was a good opportunity to have a little more relaxed start to my day before pushing all my patients to the end of the day. So that's why you get me in a tie for this presentation. But I always love talking with this group. I've probably given, or at least different members of the group today have seen part of this talk in the past, but added some new data and really excited to share. So my background, as Kelly said, is I'm really interested in exercise and lifestyle for patients with rheumatic disease. My background's in exercise science, athletic training before embarking in training in rheumatology. So really combining that past life with my current life with ongoing work we're doing. So disclosure is really just ongoing support from the NIA, which I'm thankful for. Today we'll talk about the potential benefits as well as mechanisms for how exercise and lifestyle can improve immune function, and specifically in patients with rheumatic disease. Really touch on some of the evidence and then ongoing work we're doing at Duke. But then also discuss at the end briefly just some more practical tips and some resources for this topic. I'll start the presentation with a case. This is a patient of mine, patient M, who when first saw her, she was 79 years old, has seropositive rheumatoid arthritis, but several comorbidities, including osteoarthritis, AFib, osteoporosis. I would define her as having phenotypic frailty, having weakness, exhaustion, fatigue, slowness, and really low physical activity levels. And despite medications for RA, including certolizumab and hydroxychloroquine, she still had moderate disease activity, so multiple swollen and tender joints, elevated inflammatory markers, notably really poor patient global assessment. So for the rheumatologists in the group, a question I'd like to ask is, I think we all agree that a change in therapy is indicated, but what is that change? Do we consider just changing her medications, pharmacologic therapies? Do we consider lifestyle medicine, or perhaps both? And then we'll come back to this case at the end to see what I did. Before moving forward and talking about lifestyle medicine, I really like this quote. It's something that stuck with me and throughout my training from the WHO. And it states that health is the state of complete mental, physical, mental, social well-being, not merely the absence of disease or infirmity, which I like that. But I have some issues with it in that I think it puts health and then disease on one continuum where you can't really necessarily be fully healthy if you have disease. And so I add to this quote by saying that health and well-being should be pursued even in the presence of disease or infirmity. And I think of it as potentially two continuums where we have disease and health. But unfortunately, a lot of our diseases, especially rheumatic diseases and arthritis, we don't have cures for. And so consideration is that even if we can't cure those diseases, we can still live well. And so that's just where the two lines are meeting. You might have disease, but our goal is to still have you live well in the disease. But perhaps things that are helpful for wellness also can move the needle on the upper line as well, which we'll talk about. What is lifestyle medicine and why is it important to consider in rheumatic disease? This is from the American College of Lifestyle Medicine. Just highlights the six key pillars, includes healthful eating, physical activity, managing stress, maintaining, forming healthy relationships, improving sleep, and avoiding substances. The focus today, I'm really talking about immune wellness. So we think about these things as being important to our overall health. We often think of cardiometabolic disease as being really important when it comes to lifestyle medicine, but here, hopefully, I'll give you an idea that we potentially can really impact the way our immune system functions through these pillars. Why would we consider lifestyle interventions for patients with rheumatic diseases? This figure is several years old now, but I think gives a good overview of the rationale. The idea that our autoimmune rheumatic diseases are defined by inflammation, and that contributes to multiple negative effects, poor clinical outcomes, poor muscle mass and function, and contributes to low aerobic fitness. We have a lot of therapies, including glucocorticoids. Think of prednisone. We have disease-modifying antirheumatic drugs, or DMARDs, and then biologic DMARDs that can block inflammation, but don't necessarily get at some of the other issues that inflammation can cause. And they also have adverse effects that they can cause as well, including suppressing the immune system, leading to infections, as well as increasing risk for cardiometabolic disease, and really impacting muscle and bone health. Whereas lifestyle and exercise in particular, what I'll talk about today is that it can impact potentially the inflammatory pathways and also potentially block some of the adverse effects of the medications, or at least blunt them. This is the current state of the guidelines when it comes to lifestyle medicine for our patients. And this is specifically for rheumatoid arthritis. This is the ACR guideline published a few years ago for exercise, rehab, diet. And the chart is just a general overview of the recommendations. And the thing I like to point out from this chart is that there's only one dark green box, and this is for consistent engagement in exercise. Everything else is either light green or light red, which is a conditional recommendation. So I think this is a good starting point where, yes, we should be recommending consistent engagement in exercise, but we have a lot of work to do in terms of making more specific recommendations about types of exercise, exercise prescription, as well as everything related to rehab, diet. You'll notice that there's only one conditional recommendation for Mediterranean style diet and nothing else. So we have a long way to go. But we'll talk a little bit more about the evidence for each of these pillars. So the top left, I have the pillars again, and we'll walk through at least some of the evidence and things that I consider based on the evidence for how we prescribe different lifestyle pillars for our patients. Starting with exercise, a topic that admittedly is probably my biggest interest. I spend my most time thinking about. I'm not saying it's more important than any of the others, but at least that's what you're getting today from me. This figure I made a few years ago, highlighting what we know about the negative effects of physical inactivity, sedentary behavior on the left, and then the benefits of physical activity and exercise on the right. Whereas we can, some of this stuff is fairly obvious in terms of physical activity contributing to metabolic disease, poor physical function, exercise intolerance, whereas physical activity can help with a lot of those cardiometabolic negative outcomes. But there's other things on here to think about where exercise and physical activity can really impact RA disease remission and be an anti-inflammatory therapy. It can improve pain. It can improve sleep. It can improve mental and cognitive health. So it goes beyond just our typical cardiometabolic benefits. We'll start with what we have learned over the past 20, 30 years in terms of exercise for our patients with rheumatic diseases. Unfortunately, prior to about 20, 30 years ago, there was concern that exercise could be harmful for our patients, particularly with rheumatoid arthritis. So we actually used to recommend bed rest for people who had flares. I think we know now that that was probably a bad recommendation. But this study is really instrumental in my mind in trying to understand that. This is from a group in the Netherlands who looked at participants with rheumatoid arthritis and did an intensive exercise training program. It included aerobic and resistance exercise over 2 years, which is a pretty long study for this type of work. What they're really interested to see is if exercise had an impact on disease progression based on X-rays. So I think they X-rayed a bunch of joints at baseline and over the course of 2 years and really saw and tried to figure out what happened. First, I should say that they found a lot of benefits in terms of improving patients' overall health. What they also found is that overall there was no impact of the exercise program on radiographic progression. So ultimately, the takeaway was that patients with RA could safely exercise without risk of progression. I think it's important to note there are a few caveats, and those who had baseline more advanced disease or had a lot of damage or severe degenerative changes, in particular in the shoulder glenohumeral joint as well as the subtalar joint of the ankle, those two joints had some progression in the radiographic findings. So to me, my takeaway is that exercise is safe, but in those who have advanced disease and damage, we need to be cautious, at least with our exercise prescriptions, and perhaps progress more slowly. Spondyloarthritis is another area where I think there is some question marks about where the sweet spot is, so to speak, for exercise. We know overall that exercise is good for patients with spondyloarthritis. However, there is some potential risks of high impact, high intensity exercise, as this figure is highlighting. And this has to do with what we think about the known pathophysiology of spondyloarthritis and the localization of arthritis. In particular, the sacroiliac joints, which is a really high loading, perhaps the highest loading joint within the body. It connects the lower extremity into the spine, as well as the enthesis as being a primary location of disease. The enthesis being the attachment site of tendon or ligament to bone. And if you think about the muscle tendon bone complex, the enthesis really uh, takes on the highest loads within that complex. So there's consideration that biomechanical stress could contribute to the inflammatory pathways. So we need more data here, but at least right now, knowing based also on the epidemiology of the disease, more frequently in younger men, those with more of a working class or athletic background, we have to be cautious with potentially high intensity or really high ballistic exercise and Olympic style weightlifting, but more to come hopefully here. Medications is a really important topic that we know that some of our medications can impact how exercise interventions work. We think of steroids, prednisone, as contributing to loss of muscle mass and function. That's been known for a while. But there's growing evidence that our biologics also may impact the impact of exercise. And in particular, our IL-6 inhibitors are a concern. And this was based on some initial work in patients who did not have autoimmune rheumatic diseases. This group was looking at the effects of blocking IL-6 during exercise in people who were, I think, just middle-aged, overweight, or obese. And what they did is they randomized participants to either getting placebo or an IL-6 inhibitor, or tocilizumab, or Actemra as we use. And everybody did an exercise program. What they found is those who had the placebo, who actually had IL-6 active, had a reduction of their visceral fat mass with exercise, versus those who received tocilizumab had no effect in reducing visceral fat mass with exercise. And this made some mechanistic sense because we in rheumatology generally think of IL-6 as a pro-inflammatory cytokine, but it's really a pleiotropic protein that has a lot of effects in other areas, in particular metabolism. IL-6 is actually released as a myokine during exercise and is really important for lipolysis and driving conversion from carbohydrate to fat metabolism with prolonged exercise. So it makes some sense if you blocked IL-6, you might not get the release of lipid and kind of utilization of lipid with exercise and won't have a reduction in visceral fat mass. And the group has followed this up looking at patients with rheumatoid arthritis, and they looked at an exercise intervention where they just included patients with RA who are on an IL-6 inhibitor or a TNF inhibitor. And they similarly found that despite a lot of benefits from the exercise program, those patients who were on an IL-6 inhibitor or a TNF inhibitor had no effect in reducing their visceral fat mass. And this just shows the no change between baseline and follow-up, which I think was 12 weeks. And this actually is something that we've seen in some of our studies in rheumatoid arthritis. In particular, we found that people who are on TNF inhibitors had also not had any reduction in their visceral fat mass and just fat mass in general after exercise training. So I talked about IL-6. TNF is also important in terms of regulating fat metabolism and helps contribute to lipolysis and utilization of fat as energy source. So just some considerations that these medications have impacts beyond just their anti-inflammatory properties. Now, I gave some cautions about exercise, but I want to highlight that overall the evidence supports that exercise really can be disease modifying and reduce disease activity in multiple patients with rheumatic disease. This includes lupus, spondyloarthritis, rheumatoid arthritis, myositis. And then there's a lot of problem-specific benefits in terms of improving muscle health, reducing cardiovascular disease, improving joint and bone health, decreasing pain and fatigue, but also improving immune health and potentially really improving immune function, or as I say, immune competency. And I think there's multiple pathways that this might work on, and I'm going to highlight some of this with some of the work we've done later. But on the left, or on the right, sorry, is what we currently know about the potential mechanisms in terms of how exercise can impact immune function specifically. Exercise um, really can drive a stress response. It's part of how exercise works. So our immune cells are highly sensitive to adrenergic signaling. So release of epinephrine, norepinephrine during exercise helps to stimulate and mobilize our immune cells. We know that at least during acute bout of exercise, our natural killer or NK cells are significantly upregulated or increase in the periphery and seem to be key in the exercise immune response. We also think that exercise has an impact on clearing our aged or senescent cells, but also potentially clearing what we call immunologic debris. Think of things like DAMPs and PAMPs and things that are triggering our immune system. Exercise may stimulate our immune system to get rid of some of this stuff, which could lead to some of the benefits we see. And then something I'm really interested in is this concept of muscle immune crosstalk. And IL-6 is a good point of evidence here, where we release IL-6 during exercise to help with metabolic pathways, but it also seems to influence immune cells and potentially help with kind of the resolution after exercise and triggering more of an anti-inflammatory response. So there's more to be learned, as we'll discuss later. Some further evidence in our patients about what are the pathways in terms of exercise and how they impact immune function. This is work from Sarah Patterson at UCSF, looking at a cohort of patients with lupus, and this is cross-sectional data. But what they were able to do is really identify physical activity behaviors and split the group into those who were physically active versus those who were physically inactive. And then they drew blood and collected peripheral blood mononuclear cells, or PBMCs, and did single cell RNA-seq analysis, so really looking at gene expression within individual immune cells. So here we're showing CD4 positive T cells and CD8 positive T cells. And you can see that those who were physically inactive or had more sedentary behavior, their immune cells were really skewed towards pro-inflammation. And some of this stuff should be familiar to the group in terms of the biggest signal was TNF signaling versus NF-kappa B. There's also the IL-6 JAK-STAT pathway, among others. On the opposite end, there seemed to be a downregulation of oxidative phosphorylation, or really kind of a dampening of the metabolic pathways within those immune cells. So they were skewed more towards mTOR signaling, which we won't go into all the details there. But to me, the mTOR is important for anabolic processes, things that help build our cells, help with the cell proliferation, potentially cells going into different organ systems to cause their inflammatory response. So there seems to be inflammatory pathways as well as impaired metabolism is part of how physical activity contributes to our immune dysfunction. Now, our group at Duke has looked at the exercise training response, and this is some of the initial data that we found in our HIT RA study, so high intensity interval training. study for patients with rheumatoid arthritis. This was a 10-week treadmill-based HIT program. And we found a lot of benefits from that program, um, in particular improvements in disease activity. But some of the initial work led by a collaborator of ours, Dr. David Bartlett, who's now at the University of Surrey in the UK, collected immune cells before and after a training program. And so really found some really marked changes in immune function after the program. Starting with neutrophils, found that the chemotactic index, so really think about the speed of a neutrophil's ability to respond to like a chemokine or move across a plate in ex vivo, really significantly improved. Really, these neutrophils almost improved their speed like by 100%. They doubled their speed after the exercise program. And then monocytes were better at phagocytosing E. coli. So looking at how much fluorescently labeled E. coli the monocytes were able to eat after the program significantly improved. And then work that we later did with T cells is that metabolic function, in particular CD4 positive T cell respiration or oxidative metabolism, improved in concert with changes in fitness or VO2 peak. So changes in fitness were highly tied to the metabolic changes within the T cells. So really highlighting that we're improving immune function across multiple pathways, which we'll talk a little bit more about our recent stuff upcoming. We'll switch gears and look at some of the other pillars, just so I don't spend my entire time today talking about exercise. Um, we'll start with mindfulness and stress reduction as really being an important pillar, but also a potentially important pathway to improving health in our patients. This is a study looking at mindfulness-based stress reduction program for patients with rheumatoid arthritis. What they found after an 8-week intervention is that disease activity significantly improved versus a control group. What I find fascinating about this data is that even though there was improvements after the 2-month program, when they followed them out to 4 and 6 months after the program, there was sustained and actually further reduction in disease activity. So highlighting the potential for stress reduction as a anti-inflammatory intervention. The mechanism of that anti-inflammatory intervention is likely through the vagus nerve, although we need more data. The idea here is that the vagus nerve is the dimmer switch for inflammation. This is a slide I've modified from my colleague Dr. Neha Shah at Stanford, who presented ACR this last year. But I like it because it highlights this concept that 75% of the nerves that stimulate relaxation travel along the vagus nerve. So think about the vagus nerve being parasympathetic response, so rest and relaxation and digestion. But in particular, there's direct innervation with the spleen. And that's where we think a lot of the specific immunologic benefits of vagus nerve activation go through the spleen, interactions with immune cells there. Indeed, we have ongoing evidence for the benefits of vagus nerve stimulation with the recent approval of the SetPoint medical device, so the implantable device on the vagus nerve where you stimulate the nerve just once a day for a minute, and you can get significant benefit in terms of reducing inflammation. So it's really a direct pathway. I think, at least the way we theorize it, is that stress reduction programs probably also work along this pathway. So it'll be interesting to see how that might synergize with some of the vagal nerve stimulation programs that we're planning in the future. We'll move on to sleep, which I think is one of the more understudied areas within lifestyle medicine for patients with rheumatic disease. I think we're still at the point of trying to understand the problem and the scope of the issue, and then hopefully we'll be working towards interventions. This is probably should update it. This is actually a study Patty Katz and team from UCSF published in this year, actually. It's not 2023. But this was looking at a cohort that they had at UCSF where they were really looking at sleep based on this WatchPat device as well as the actigraph. So really trying to understand um, sleep disorders in patients with rheumatoid arthritis. And what you notice is that overall we look at the cohorts of 56 patients who were on the watch pat and then the 116 on the actigraph. Almost all of them had some sort of sleep disorder, whether that was poor sleep efficiency, short sleep duration, or evidence of obstructive sleep apnea. In particular, it was the poor sleep efficiency that was an important thing in terms of being associated with disease activity in RA. And sleep efficiency, I believe, just meant that of the time spent in bed, how much was that actually sleeping versus just laying there? I think those with poor sleep efficiency had less than 80 or 85% time. So potentially a important metric for us to think through in the future. The mechanism of how sleep can be anti-inflammatory also, I think, needs further evidence and data, but we think of it similar to how we think that stress reduction can be beneficial. The idea being if you're not getting good sleep, you're in a higher sympathetic or arousal state. And so the increased sympathetic nervous system activity, reduced parasympathetic or vagus activity is potentially going to skew towards more pro-inflammatory state. At least that's the simplistic way that we think about it, but there's probably other pathways that are impacted within inflammation by not getting consistent regular sleep. Next topic is food and diet. Perhaps at least my bias was that this was the most important topic for our patients, at least something that my patients always asked about. We've learned that maybe sleep is also right up there in terms of importance. But it's a question I get asked all the time in terms of what is the best diet to improve inflammation for my condition. And I think there's growing evidence that there could be multiple diets. There's not a one size fits all here. But the evidence, as we'll discuss, really centers around a Mediterranean style diet or a whole food plant-based diet. And so we'll start with the med diet as really, I think, just has the best evidence. Not necessarily saying it's the best, but it has the most evidence. And this is one of the first studies done in Sweden for patients with rheumatoid arthritis, randomized to a Mediterranean diet versus a regular diet. Mediterranean diet includes things we're likely familiar with in terms of a lot of fruits and veggies, olive oil, whole grains, beans, legumes, protein from the plant-based sources or fish, but also including dairy as well as poultry, but limiting red meat, sugar, processed foods. And what they found in this study is that the intervention significantly improved disease activity, and it was in a lot of ways a proof of concept that dietary intervention alone could be disease modifying. We'll move on to thinking about how essentially a whole food plant-based diet can be beneficial. This is one of the first studies to look at this, also from Sweden, looking at a combined vegan and gluten-free diet. So the vegan diet included what you'd expect in terms of a vegan diet and gluten-free diet as well. What was impressive is this study was for 1 year. So they had patients with RA on stable meds and included them in the study for a year. What they found was the vegan gluten-free diet had a significant improvement in disease activity. 34% met ACR 20 criteria versus the control well-balanced diet, only 4%. What's notable to me, as I put here, is that the dropout rate was very different, as in only 11% in the control group dropped out, but 42% dropped out in the vegan gluten-free diet, highlighting that potentially that diet's not for everybody. And so perhaps the best diet is going to be something that someone's going to maintain over time. But for those who this makes sense, a vegan and gluten-free diet could be beneficial. The trouble right now with the data is that we can't necessarily separate the vegan and the gluten-free. We haven't had great data on just a vegan diet or just gluten-free diet. So unfortunately, I can't comment further about that right now. We have a lot of uh, consideration for how elimination style diets can work. So previously, this is a few years ago, when you would Google search anti-inflammatory diet, the top hits that would come up would be these elimination type diets. So the autoimmune protocol being maybe the most common, but there are other ones out there. I think fortunately maybe in the age of AI, when you Google search anti-inflammatory diet, you'll get a more nuanced response in terms of how Mediterranean style diet and plant-based diets can be beneficial. But when we're thinking about plant-based elimination type diets, this is, I think, some of the best evidence we have for our patients. So this is a randomized crossover design trial of patients with rheumatoid arthritis. And they went through a phased elimination style diet. So what they did was the first 4 weeks did a vegan diet, then 3 weeks where they eliminated a lot of other things, which we can, if we have time, discuss the potential benefits or not of limiting all these things. But most importantly, they had 9 weeks of trying to reintroduce as much of this back into the diet. These elimination style diets are based on the idea that you can have reactions or intolerances to some of these foods that could drive inflammation. So you're trying to figure out what is driving that based on the elimination and reintroduction. The problem is that these were always designed for just short periods of elimination. And unfortunately, I've had a lot of patients come to my clinic who have tried to maintain on these elimination style diets long term and unfortunately present with a lot of nutritional deficiencies. So there's just got to be a lot of caution with using these because I think they can be beneficial. As you'll see on the table, there's benefits in terms of the cardiometabolic effects, but also potential benefits in improving disease activity. But again, more of a short-term um, diet. More recently, there's growing evidence for kind of combining some of these concepts. And so the ITIS diet that was designed and is ongoing study from Dr. Monica Guma's group at UCSD really puts a lot of this together in terms of plant-based diet as well as Mediterranean style diet. You can see the ITIS diet includes also pre and probiotics, which we'll discuss. There's a lot of considerations for what really is an anti-inflammatory vegetable versus a pro-inflammatory vegetable. I will say in general, these pro-inflammatory vegetables are the nightshades, so things like potatoes, peppers, eggplant. And my bias is that there's not enough data to suggest that these are truly negative because they can have a lot of positive benefits. Think of tomatoes and peppers and eggplant generally having a lot of nutritional value. So I think there's maybe only a subset of patients who really would benefit from that. But I won't argue with what Monica did because there seems to be a lot of benefit from this diet. And the figure is showing some of the preliminary data they found from just 14 days of this diet in terms of improving disease activity across multiple metrics. What they also found was that the baseline microbiome and diversity and other factors in the microbiome were highly linked to that response. And so there's a lot of promise potentially to trying to individualize or personalize dietary modifications. So hopefully we'll learn more about it. Monica Guma has multiple studies ongoing. She is a randomized trial comparing Mediterranean style diet to this diet. And we'll, again, hopefully learn more about that soon. I'll briefly mention this study is another area that we need to better understand, and that's how improving gut health could be useful for improving inflammation. And in particular, the benefit of fiber and fermented foods. So this is a group at Stanford studied patients without autoimmune or rheumatic diseases, and they first at baseline identified patients and broke them into groups, starting with high inflammation to low inflammation. And what they found is that inflammation was highly linked to microbial diversity. So this ASV is their gut microbiome based on fecal samples. Those with low diversity had high inflammation. Those with high diversity had low inflammation. And then you randomize them to high fiber or fermented food diet. The high fiber group had really individualized response. There was increase in microbiome function, increase in things called cazymes and short chain fatty acids. So the microbiome was more active after high fiber, which we think of as being your prebiotic or the fuel to help grow and activate our probiotics or healthy or good bacteria in our gut. But depending on the baseline diversity, those who had low diversity at baseline actually had increase in inflammation versus those with baseline high diversity had a decrease in inflammation versus the fermented food diet. There was, as expected, an increase in microbiome diversity, and by fermented foods, they actually had 6 servings of fermented foods a day, or 3 meals a day. So for breakfast, they had yogurt, like Greek yogurt or kefir. For lunch, they had a non-alcoholic fermented drink, such as kombucha tea. And then at dinner, they had a fermented vegetable, such as sauerkraut or kimchi. And this is over the course of 16 weeks. And increase in microbial diversity, but also decrease in inflammatory signaling. The takeaway is that perhaps there's something to first increasing microbiome diversity prior to really recommending a high fiber diet. But there's a lot more we need to learn in terms of how this might affect our patients. So I've highlighted how individually the lifestyle pillars can be beneficial for immune health, but there's ongoing consideration that combining these might synergize. And so I think the evidence so far is suggesting that yes, combining these lifestyle factors really can have more benefit than just having one lifestyle factor change. So this is evidence from the Plants for Joints study, really an important study from the Netherlands, highlighting how combining a whole food plant-based diet, physical activity, and stress management program, really think of the group sessions, group counseling, and group coaching sessions over the course of 16 weeks, significantly improved disease activity in patients with RA and baseline moderate disease activity. And that those effects were found at 16 weeks, but also sustained at 1 year. And so there's a lot of ongoing benefit even after the intervention. At Duke, we've also looked into this question with the Sweat RA study. So, supervised weight loss and exercise training for RA. A study we completed a few years ago now. But what we did was randomize patients who were older, overweight, with seropositive rheumatoid arthritis to the SWEAT program, or CHAT. CHAT stands for Counseling Health as Treatment, as an idealized control group where they had a meeting with an exercise physiologist for 1 hour and then a dietitian for 1 hour to really talk through planning exercise and dietary changes. Then the sweat group, we pivoted to online remote program during the pandemic. So the program was aerobic training and resistance training delivered via Zoom, but also via YouTube videos, which I show here and have a link to those videos, as well as weekly visits with a dietitian to work on a generally well balanced but hypocaloric or caloric restriction diet. What we found was that the more intensive sweat group had significant improvements across multiple metrics compared to the chat group. In particular, disease activity improved in sweat and to a greater extent than chat. But also patient-reported outcomes, at least after the 16 weeks, improved in sweat versus chat, including physical health, physical function, um, mental health, as well as fatigue, with trends towards improvement in cognitive function and pain. But I'll highlight as well that the chat group, although they were the control group, they had a lot of improvements that were perhaps beyond what we expected. Interestingly, their increase in their step counts was exactly the same as the sweat group. So just doing that counseling seemed to have an impact, or maybe this is just a really highly motivated group. So what we've done further is really look at these groups combined because there's a lot of benefits across the board, although some variability in chat. But before I get to that, we'll talk a little bit about what was the potential impact of each of the components. So there was 3 components to our intervention. One was the hypocaloric diet, the other was aerobic training and resistance training. We tried to break these down to understand what was the what was the biggest benefit for any given outcome. And so we used canonical correlations analysis to try to get at this, where reductions in fat mass were most closely linked to improvements in metabolic syndrome, which made some sense. So the diet had the biggest impact on cardiometabolic health. The aerobic training program and improvements in VO2 or cardiorespiratory fitness had the most benefits in terms of fatigue and physical function. whereas resistance training and improvements in muscle strength were most linked to improvements in disease activity. So this is an area I've really tried to dive into. What is it about resistance training that maybe has the most um, immunomodulatory or effects on the immune system? So we've tried to dive into this question since that study ended. And so we collected plasma as well as peripheral blood mononuclear cells and have ongoing analysis along these lines. So the first question we asked was whether exercise and diet had an impact on immune signaling or just plasma cytokines. So we did a large panel. I'm showing some data here of cytokines that are important both for rheumatoid arthritis, but also they're important for aging and senescence or the SASP or senescence-associated secretory phenotype. And ultimately, we really didn't see changes as you might expect. So there was no changes across the board in these cytokines. This is showing both the sweat and the chat groups next to each other. If anything, there's actually an increase in a lot of these more pro-inflammatory or senescence-driving cytokines. So that made us curious about what was going on, given that we've seen improvements in inflammation based on disease activity and other metrics. So a medical student in our group, Hannah McClellan, has been diving into this and really looking at associations between changes in these immune signaling proteins as well as with disease activity. And what we're seeing is fairly striking that there really wasn't a correlation between changes in the immune signaling markers with disease activity across disease activity, the DAS28, and the components of DAS28, including the inflammatory markers, the ESR, CRP, patient global, tender, and swollen joints. When we look at the disease activity in 28 joints or DAS28 CRP, it's actually a negative association. So what I'm showing here is a heat map of Spearman correlations, where red is a strong positive correlation and blue is a strong negative correlation. And if anything, we're seeing negative associations between disease activity and changes in cytokines after the intervention. So, if anything, reductions of disease activity are associated with increases in a lot of these cytokines like IL-17, which is maybe the opposite of what you might expect. So, what is the reason for why we're seeing that unexpected result? So Hannah's looked into this a little bit more and actually found that the changes in immune signaling were highly associated with changes in muscle health and really improvements in muscle health. And so, in particular, leg strength over here, another heat map looking at correlation coefficients. We can see that increases in muscle strength really across the board were associated with increases in a lot of these. Again, you consider them pro-inflammatory cytokines. IL-10 being maybe a difference is being more of an anti-inflammatory cytokine, but also seeing um, associations with changes in biomechanical properties. So we used a device called the Myoton Pro to measure stiffness, tone, elasticity of muscles. We looked at the forearm, the biceps, the vastus lateralis, as well as the tibialis anterior. And in particular, looking at the biceps, there is this really strong relationship between increases in biceps tone and multiple markers of these immune signaling proteins. So, what is it about muscle that is maybe driving some of these immune signaling changes? Well, to me, it really begs the question is whether what we're seeing exercise training is really training the muscle repair response that is leading to improving immune competence. So, after exercise, and in particular resistance training, there's muscle damage. There's micro tears in the muscle. And our immune system is really integral to the repair process of muscle. And it's the reason why we get stronger and our muscles get bigger after repeated bouts of resistance training. So you can see that there's multiple immune cells that are part of this, including our lymphocytes, as well as macrophages. Importantly, there's this regulated response, or really a response where there's inflammation to begin with, and then hours and days after exercise, you have a inflammation resolution or anti-inflammatory response to resolve that inflammation. And on the right, you can see that a lot of the proteins we were looking at, including a lot of the proteins we think about as being important in rheumatoid arthritis, TNF alpha, IL-1, IL-6, as well as some of these cytokines we see in the aging senescence profile, IL-8 and MCP-1, are really key in driving the muscle repair process. So if we think about kind of this is canon for how we think exercise has its benefits, that you have, untrained response when you start exercising. After repeated bouts of exercise over weeks and months and years, you get to a point where you're trained and you improve your exercise performance. But the acute response to exercise also gets trained. And so all the factors that contribute to the benefits of exercise get trained. So theory would be that perhaps repeatedly training the immune repair response is really allowing our immune system to be more fit as well and really improving immune competence along the line along those lines. So at least that's what we're theorizing, but something that really needs to be studied further. But a really interesting area of why strength training, resistance training, seems to have the strongest benefit from what our data is showing for immune function improvements. Finish with some really hot off the press data that we just got. Looking at some changes in our immune phenotypes after the exercise and diet intervention. And so what we did is we collected PBMCs and then really did a lot of flow cytometry analyses to really understand how the phenotypes of our lymphocytes changed. And so ultimately, we're seeing that there are markers of aging that are improved after the intervention. So in the periphery, at least, we have reductions in Tregs. We have an increase in our naive T cells, or CD4. So naive cells, really important for immune surveillance, and often decrease with aging. And then we have reductions in our KLRG1 positive NK and NKT cells. And these are really markers of senescent cells that are decreasing. So overall profile is showing a reduction in the aging immune response. So more to come on this. I'll finish up just briefly talking about practical aspects of this and how I approach it in clinic. Um, to me, when it comes to exercise, we should be specific in terms of the recommendations we're given, even though we don't have all the data we want to guide the prescription. I think we need to include minimally components of aerobic exercise as well as strength and resistance training exercise. This is just a handout that I made as part of the Exercise is Medicine RX for Health series from the American College of Sports Medicine. Some of the key aspects I think about is really starting slow. The idea that even though there's this recommendation for adults to get at least 150 minutes a week of moderate intensity aerobic exercise, a lot of our patients with rheumatic disease cannot quite do that. And it really starts with maybe, you know, 2 to 5 minutes at a time, slowly building up to 30 minutes a week, and then so forth. And same with strength training. I think it needs to start slow. There's a lot of ways to do this. We use resistance bands for our remote program, but body weight, Pilates, all the machines and equipment at the gym, there's a lot of ways to do this as long as we're starting slow and building over time. I think there's a lot to consider in terms of the specific diseases we treat, and I went over this earlier with some of the data, but my bias is that not all arthritis is the same. I think it really depends on the type of arthritis and how it affects you and how we prescribe exercise. I think all exercise should be performed in pain-free ranges of motion, but those who have RA or hand arthritis, we need to consider that maybe like gripping heavy weights can be difficult. So using either resistance bands or hand and wrist supports to help with the exercises can be useful. For those with lower extremity or spine arthritis, I think about how walking can be challenging for those individuals, meaning that walking actually puts a lot of load to the spine and lower extremities. So offloading exercise such as cycling or swimming or water aerobics is really a potentially good way to go. I already talked about spondyloarthritis and that biomechanical stress could be impactful. For SLE patients, think about just being outdoors and how the photosensitivity can be impacted. Fibromyalgia is something I didn't talk a lot about today, but something I really have to consider in terms of those with post-exertional malaise, the idea that they have flares that occur in the hours or days after exercise that can take many days to recover from. Really need to be thinking about slow progressions and this idea of activity pacing or not pushing past your limits. Flares is an ongoing question of how we manage flares, but to me, a longer warm up and cool down is really important, starting with lower, lighter intensity and progressing from there. And then morning stiffness, considering how we really incorporate mobility and flexibility activities throughout the day. Diet, I think there's a lot of resources out there. This is, I think, one of the best from Dr. Sarah Patterson at UCSF, putting together some information on the anti-inflammatory food pyramid, also discussing just how to kind of put this into practice. And with Sarah, we've put together a group called Calm Room. So Sarah and I are the co-chairs of this. It's a U.S. or North America-based consortium. It says Consortium to Advance Integrative and Lifestyle Medicine and Rheumatology. We now consist of about 30 rheumatologists and academic and researchers throughout the country. We're really trying to do what we say in the title, advance lifestyle medicine by trying to understand gaps in the data, trying to put resources together. We have a lot of projects we have planned. We've already started by trying to put a lot of resources together. This is one example of where we've started. So this is actually something we shared at last year's ACR. You can use the QR code that hopefully will link to the PDF. Let me know if it doesn't. But this includes a lot of resources, including I think the wonderful Prevail exercise resource that Luis Toma and group has put together at UNC. But I think there's ongoing needs to expand this and at least have a place where all these resources can be gathered by both patients and providers. We have hopes for building a lot more within this group. So be on the lookout. Hopefully, we'll have a website up and running soon, but then more resources and programs to come. So to finish, we'll come back to our patient. So Miss M is now 3 years after we first saw her, and the main intervention that she received was participating in the Sweat RA study. So she did the intensive supervised weight loss and exercise training program. And we can see that she is now 82, still a seropositive RA, but a lot of things have changed. She's actually reduced her medications as opposed to increasing medications. So she reduced her dose of certolizumab. She's stopped her hydroxychloroquine. Her disease activity has now dropped from moderate to now remission. That's really across the board. So CRP, ESR have come down. She no longer has swollen or tender joints, and her patient global, which I find most impressive, is now 0. So she is doing as well as she possibly could be. Was doing so well, in fact, that she got back on her ATV. She loves riding her ATV, and had an accident where she was thrown off the ATV, but importantly had minimal injuries, was able to bounce back, or I'd say that she was resilient and was right back to her program. So I think if she'd had that issue before this program, I'm not sure she would have had the same positive outcome. So take home points, lifestyle interventions really should be considered. I think they're integrative interventions. I really think they can synergize with what we do. There's a lot of potential for how medications can impact lifestyle interventions, so more to come there. But minimally, I think they can be prescribed and should be prescribed, but we can continue to do better. So certainly thankful for my wonderful group at Duke and all of my funders. And I think we have a few minutes for questions, so I can stop share so I can maybe see chat and answer any questions.
Thank you, Brian. That was like a master class. What a great overview of lifestyle medicine and immunology. And we do have a couple minutes. If anybody wants to unmute or put something in the chat, please feel free to do that. So, Brian, I don't know if you can see that there's a question. Did you find any sex differences in your research?
So really, really good question. And actually, interesting challenge we have is that most of the participants in our RA studies were women or female. So I think it's hard to make generalizations about the data for men. We actually, I think, you can't comment. So I think everything I really told you, it's a good question, really applies to women. Actually, I've struggled to actually get men with rheumatoid arthritis to join our study. So actually, if you guys have patients who you think might qualify for ongoing work, I think actually men, surprisingly, are one area that we don't have data on. So thanks for that question.
Other questions? Lots of comments about great talk.
Well, always appreciate it. Like I said before, I think there's a lot of room. We do a lot of, I think, synergistic work between Duke and UNC. So always happy to keep collaborating, and it's been wonderful collaborating with Luis and team and everyone at UNC so far. So I'm hopeful that it's more to come there.
Yeah, that's great. And as you said, there are already some strong collaborations, but for those of you who aren't already collaborating with Brian and others at Duke, please do reach out. I think there's a lot of good opportunities for synergies.
Brian, I have a question. Clinically, what do you feel like when you're talking about lifestyle approaches with your patients? Like, which are the most challenging to get buy-in, or is it, more person specific? Just some insights from the kind of clinical
Yeah.
aspect of implementing this.
There's so much that goes into that, Luis. I appreciate the question. To me, I think some ways my clinic is a little biased. I think people self-select to see me, and I have a lifestyle clinic that I've started at Duke, where patients just come to see me for that issue. So I think I see a maybe more biased population. Um, Something I've talked about with our group that I think depending on a lot of factors, even the disease, I think there are differences in kind of motivations. There's just so much that goes into the like motivation aspect and kind of the more behavioral aspects of exercise and lifestyle change that are tricky. Like we have colleagues who have studied other disease populations such as psoriasis and psoriatic arthritis, and anecdotally, it seems like they've been having more difficult time recruiting them to do the studies. And I would agree in my work, maybe I find it harder, even though I think that psoriasis really benefits from lifestyle modification almost more than any of our other diseases. It's just I tend not to get as much buy-in. So I think it's a really understudied area that we just don't understand all the factors that might go into the disease versus the patient. And um, yeah, I just think there's a lot to learn. So I appreciate that question.
Right, we're right at time. Thanks again, Brian. We really appreciate you taking time to prepare and be with us today, and hope your clinic day goes well.
Yeah, really again, appreciate you having me. Love to come back.
All right, great. Thank you all.